We're going underwater
Dr. Binmoeller, you
for
can start.
EMR. EMR was first reported in 1973, so nearly half a century ago, by doctors at the University of Zurich, describing a new method to resect sessile polyps. They injected a fluid depot under the colonic mucosa, shown here, to raise the mucosa from the muscularis propria to enable the resection. Now you need to appreciate how revolutionary this was at the time, because all sessile polyps were referred to surgery. So the rationale for this submucosal injection was to prevent transmural thermal injury and to prevent perforation. And this sounded logical, because when we insufflate the colon lumen with gas, we distend the lumen and this thins out the wall. And we see this nicely illustrated here with the colonoscope in the cecum, and we get this prominent transillumination. And if any of you have performed intraoperative colonoscopy, you've appreciated just how thin the colon wall is. However, the benefit of submucosal injection has never been proven in a randomized controlled trial. There's never been an RCT. What's quoted in the literature is always this study in 6 swine. And this study showed really mixed results. There was a benefit in terms of protecting against deep injury when using the heater probe or APC, and it's not surprising that APC would protect from deeper injury. But there was no benefit when using hot biopsy forceps or the gold probe. And there are trade-offs to submucosal injection. Those of us that have been performing this over the years have experienced these trade-offs. It can distort and narrow the lumen. It can displace the lesion away from the operator. You can get paradoxical flattening, and you can get back bleeding. That can impair the visibility, of course, but also triggers peristalsis. So you can take a lesion like this, a flat lesion in the cecum, and then after injection, your snare is constantly skiving off because you've really flattened the lesion itself. It really is not raised relative to the surrounding mucosa. But our needle may also go beyond the wall into the peritoneal space, and that can cause local peritonitis and infection, because after all, we're injecting through a non-sterile environment. And what we call post-polypectomy syndrome may actually be due to the injection and not necessarily the transmural burn, which we usually attribute this to. Now, one of the concerns I have always had is when we inject translesionally, can we see dysplastic cells into the deeper wall layers? We know that seeding is a known risk of FNA. Patients with HCC, for example, there's about a 3% risk of tumor seeding that's been reported after FNA. And for cholangioCA, studies have shown that there's a significant risk of peritoneal mets, and that's why today patients are not candidates for liver transplantation if they have undergone prior FNA for suspected cholangioCA. It was during one of my routine EUS staging procedures for a growth in the colon that I discovered that when we submerge the colon underwater, and that of course is needed for the acoustic coupling, the wall retains its native thickness and the muscularis propria stays round on the outside. So the MP does not follow the involutions of the mucosa and the submucosa into the lumen. So everything looks contracted here And obviously one would be normally concerned about perforation. However, the MP, when we look through the wall, is intact. So we get this floating effect when we submerge the lesion underwater. So here with gas, this looks like a Paris 2A, a flat lesion, but underwater, it souffles up and looks like a 1S lesion. And really, when you look at this, you would think that a submucosal injection had been performed. Why does the submucosa float? Well, of course, there's the anti-gravity effect, but there is fat in the submucosa, and of course, fat does float. So after resection, you can see this fat in the submucosa. And you see this fat on CT scan. The radiologists call this the black halo sign here. So it appears black on CT, but on EUS, the fat tissue in the submucosa appears echogenic. And that's why this third layer is bright. So when we insufflate gas, this distends the lumen and it flattens our lesion. But when we use water, it does just the opposite. It contracts the lesion because we're not forcibly distending the lumen, and the lesion floats. So this is nicely illustrated for this very large lesion that's perhaps as large as 4 centimeters adjacent to the AO. So it's a granular type LST, and here's the appearance underwater. So you can already see that floating effect and the contraction. Now I'm placing some diathermic markings around the perimeter to ensure that I can get my snare around the entire lesion. And after I've completely encircled the lesion with this 33 millimeter snare, we apply our current, we resect, and the resection plane is in SM2. So it's in that layer between SM1 and SM3, and SM1 and 3 are the layers that have the blood vessels. So that is why we often do not have any bleeding after underwater resection. So this contraction and floating effect is what enables en-bloc resection. So I looked at this back in 2015, attempting en-bloc resection in all large 2 to 4 centimeter lesions. And in these 52 patients, I was able to resect the lesions en bloc in 55%. Now, in an additional 17%, 2 resections were required. So about 3/4 of the patients could be resected with just 2 resections. But I want to emphasize that the additional resections are not strictly piecemeal the way it's performed with conventional EMR. I consider this more of a trimming because we attempt en bloc, but there may be some residual at the edges, and the edges then are resected with a trimming strategy. So this video illustrates how this trimming of the edges is performed. So you can see this is quite an extensive lesion. It is at the rectosigmoid junction, and I always try to resect this en bloc, but I think given its very, very large size, it would be a pleasant surprise if I succeeded. But you can see with the contraction and the floating effect, we can really get our snare pretty well around the lesion. And now with the torque and crimping, to and fro movements, so various maneuvers we use to maximize the displacement, the shift of the lesion into the snare lumen, and we close the snare, and we'll see some discoloration. Of course, it turns violaceous as we close our snare. We can rotate a bit just to assess whether we have captured at least most of the lesion. And then we apply are cutting current. And when we perform this underwater, now this is with saline, we always use saline, we also get the heat sink effect, which limits the depth of injury. But you can see here there is some residual on the side. So this is the trimming that we do afterwards. And I will usually use a smaller snare for the trimming part because it's not necessary to use such a large snare. It's easier. So what we do is always place the edge of the snare at the edge of the prior resection. So here you can see that with 2 pieces, we were able to get the entire lesion out. And this is the appearance at 8 months with scar tissue. Now we have randomized controlled trials. So now we're starting to see evidence-based medicine. So let's start first with this paper published in Gastroenterology in 2019. Japanese authors, 5 Japan centers, randomized controlled trial, 210 intermediate sized polyps, so ranging from 10 to 20 millimeters. So these authors were not looking at the larger polyps, but still, even with these smaller polyps, the en bloc resection rate was significantly higher using underwater, and the RO resection rate also significantly better. This is really the pivotal trial that was reported in 2021, and these are all large polyps, so 20 to 40 millimeters. And they found that the underwater technique was significantly superior to the conventional submucosal injection assisted technique in terms of the en bloc resection rate. So you can see here underwater versus conventional, 33% versus 18%. The R0 resection rate, again here 32% versus 16%. And the recurrence rate for polyps larger than 3 centimeters. So the recurrence rate using the conventional method, 43% versus 6% for the underwater. Also, the procedure time was significantly shorter, 8 minutes versus 14 minutes. This is the most recent randomized controlled trial. It's still in pre-proof print. This is from Brazil, 120 lesions ranging from 10 to 40 millimeters, all non-pedunculated at 2 centers. The recurrence rates for polyps 2 to 4 centimeters was significantly lower in patients that underwent underwater EMR, EMR, you see that here. And the relative risk of 6-month recurrence was found to be 7.5-fold higher in the CEMR group. So here you can see the recurrence rate, and it was 0 for the underwater group and 36% for the conventional group. Highly significant. So the number needed to treat to prevent a recurrence was 7.7. This is an interesting study that caught my eye. Now, it's not a randomized controlled trial, but this study compares UEMR versus ESD for 20 to 30 millimeter colorectal polyps. So this is from Japan, published in 2021. So you see a comparison here, UEMR versus ESD. And the en bloc resection rate with UEMR was 61% for these large polyps. Of course, ESD had a near 100% en bloc resection rate. But importantly, the procedure time was remarkably shorter using the UEMR technique. 6 minutes versus 65 minutes for ESD, and this is performed at Japanese Centers of Excellence. So I expect that in the West, this would probably have been even longer. UEMR had no recurrence, ESD also none. The bleeding rate was 5% in the UEMR group versus 2.7%, and none of the patients had perforation. But what the authors concluded was that the sample size was sufficient to prove non-inferiority of UEMR compared to ESD. So I think this is a very strong endorsement of UEMR. UEMR is increasingly being reported for the treatment of so-called defiant polyps. So here you can see, just to illustrate, the application of UEMR for a scarred lesion, 15 millimeters. This is a recurrence here. You can see the recurrence here, in this area right here, and it's very scarred. Actually, it's much larger. Here's the perimeter. So you have to look very carefully to appreciate the extent, but you see it much better underwater because it floats up and it contracts. So we're opening our 15 millimeter snare now, and we're able to completely encircle the lesion, and we push the snare firmly down. It's a stiff snare, and we allow the lesion to displace up into the snare lumen. We apply some gentle suction, so I call this the water pull, to pull that lesion a little bit more into the snare lumen to maximize our capture, the real estate that we capture. And then we apply our current. It looks like we have the entire lesion encircled with our snare. So it comes off very nicely, and this is the appearance afterwards. And again, you'll note no bleeding, and that's because the resection plane is in SM2. So it's in that sweet spot between the vessels that we have in SM1 and the vessels in SM3. So this is our en bloc specimen. It really looks as if we had performed ESD, but obviously in a fraction of the time. Here's a illustration of UEMR for an AO lesion. So this is a lesion that encircles the AO, but also extends into the AO. But when we give water, the part that's inside of the AO, it floats very nicely out into the lumen and allows us now, after we've performed our diathermic markings around the lesion and it's all nicely contracted, allows us to encircle the lesion with our snare. So once again, we are attempting en bloc resection. We close the snare, we look. We can always open the snare again and recapture if we're not happy with the capture. And this is the specimen, but we're looking now at the base. We're going to inspect the base very carefully. And you see here at the AO itself, there is some residual. But we can also resect this residual by applying gentle suctions, so this water pull effect, pulling the AO channel, which is a lumen, up into the snare and then closing the snare around that. Now, of course, we don't know how far this lesion extends into the appendix itself, and so this patient may require an appendectomy as well. But if we look now at the base, you can see it's clean, and of course we got biopsies from the base, and those were negative. So this is the appearance at 5 months, nicely scarred, and of course we biopsied this multiple times. So I reported on this experience removing AO lesions in 2015, and our complication rate was very low at 7%, only pain, but importantly, none of these patients developed appendicitis. And that is a concern when we use full thickness resection technique that is now being used using full thickness resection devices. And finally, UEMR for IC valve lesions. I reported this in 102 lesions, mean size of 3 centimeters. So this is the gas view. And now underwater, because the IC valve contains a lot of fat, it floats up very nicely, and we're able to encircle the entire lesion. So this is a 30 millimeter snare, and we're able to get it around the entire circumference. And we're using a torque and crimp technique, so torquing the snare and then crimping. So we close the snare, turns a little violaceous, and you see the snare is around the dots, and then we apply our current and cut it through. Now the fat tissue is often very vascular, so it's not uncommon to get bleeding here. We sometimes do need to coagulate these small vessels. But you can see after the resection, the ileum prolapses into the cecum because we've removed that part of the valve. So not the valve itself, but that mucosal and submucosal portion. And this was a cystosserrated adenoma on pathology. So why go underwater for EMR? Well, firstly, it avoids the potential drawbacks of submucosal injection. And it certainly reduces the procedure time since we don't need to perform that. But there is added benefit, and I think that is most importantly that it facilitates en-bloc resection. And that in turn should reduce your recurrence rates. So I would say if your recurrence rates are high in your practice, then you might consider adapting EMR. For me, it's about that underwater view, that 3D plasticity, the crisp images, the colors become more intense. I just enjoy colonoscopy more going underwater. Thank you.
Excellent talk, Dr. Binmoeller. Can I ask you a question? Has it been attempted in the duodenum as well? In the duodenum?
Yes, absolutely. So, this is an area that the Japanese are very enthusiastic about. As you know, the risk of perforation in the duodenum is very high using ESD. The wall is very thin and it is very hypervascular. Therefore, the Japanese recommend EMR in the duodenum and not ESD. And they have found underwater EMR to be particularly helpful to minimize the risk of perforation. So it's really been embraced by the Japanese in the duodenum. And I think now it's starting to gain traction in the colon. But as you know, the Japanese have pioneered ESD, so they still very liberally use ESD in the colon. But there's no question, as I showed you in this paper, that there's a significant time savings with EMR versus ESD in the colon with the same outcomes. So at least non-inferiority in terms of outcomes, but really a fraction of the time.
Okay. One more question. If some bleeding happens during the procedure, is it easy to control the bleeding like clipping, etc. underwater?
Yes. Difficult? So the answer is a yes and no. So the control of the bleeding can be helpful underwater because underwater you can see the origin of the bleed very nicely. But when the bleed is very vigorous, it starts to cloud the view. So you get sort of this reddish cloud. It's very foggy and you can't see well. That's where you need to then very vigorously irrigate, and you need to push your scope very close to the mucosa while irrigating, and that will allow you to see the mucosa and the bleeding source. But sometimes
You just have to switch the gas on and to identify the bleeding source, simply because underwater everything gets very cloudy. Now, having said that, the Japanese have this gel, and you may have seen some of their beautiful gel immersion videos. And this is a substance that is that basically clears up the view very nicely, and then you can actually see the bleeding source very nicely. This is not available here in the United States, but it's a remarkable gel that clears the view.
Last question. The cautery settings, are they different from conventional EMR?
Yes. So you need to sort of test yourself to see what works for your unit. You do get the heat sink effect when you do resection underwater. So that protects against deeper thermal injury. So you shouldn't be afraid of using high coagulation settings. It's not an issue. But in terms of the rapidity of the resection, I actually tend to prefer using pure cutting current. And I get enough coagulation, and if you want a little bit more coagulation, just tap intermittently, and then you get a greater coag effect. But this is really something that I think each operator should just play around with and find out what works best for you.
Thank you very much.
Ken, Yogesh here. Ken, very nice talk, excellent talk. I just want to ask you a very basic question. You are the first to start EMR. You gave this concept. So what made you say that? I have seen it in a video and a talk. I want our audience to know what gave you the idea. And this is a unique idea. So what was it which put you through?
It's really serendipity. So I perform endoscopic ultrasound, which of course requires a water submersion. It needs a water medium for acoustic coupling. And as I described in my talk, one day while I was staging a cancer in the colon, I realized that even though endoscopically there was vigorous peristalsis and contraction, the muscularis propria just stayed on the outside round and didn't follow the involutions of the mucosa and submucosa. And I realized then that if you perform the resection underwater, you preserve the native thickness of the bowel wall. And it's really remarkable when you distend how thin the bowel wall becomes. But not only that, really there is no risk of accidentally capturing the muscle because it stays on the outside with water submersion. At first, of course, I was hesitant to just start resecting without submucosal injection. So I started first with submucosal injection, but doing this underwater. But what I then found is that when you perform submucosal injection, you decrease the compliance of the submucosa. Yes, I'm sorry. So basically the bottom line is that it was an evolutionary step to underwater EMR without submucosal injection.
Ken, thanks a lot for the excellent talk. We can go to the next talk.
My pleasure. Thank you.